Well, thank you all again for joining us. Today, we're going to be discussing optical coherence tomographic angiography, OCT-A or OCT angiography. Now, most of us are pretty familiar with OCT in ophthalmic practices. It's the most widely used diagnostic tool that not only for making initial diagnosis of retinal pathology, but also to follow treatment and see if there's any change in that retinal pathology. OCT uses a non-invasive near-infrared wavelength of light that passes through tissue in the back of the eye and is reflected back, and we record it using interferometry. So we use this technology, OCT, in OCT angiography. It's the same thing, basically. There's non-invasive, uses a near-infrared wavelength of light, and we're recording the tissue in the back of the eye. There's a couple of big differences, but let's talk a little bit more about OCT first so we all have sort of the basic groundwork to work from. So OCT gives us this tomographic slice of the retina, sort of a biopsy without surgery, if you will. We can see all the different layers of the retina from the top ILM all the way down to the retinal pigment epithelium, and even past that into the choriocapillaris, and sometimes even into the choroid. Now, this is like looking at a slice of a hillside, if you will. So if we're looking on top of this, we're flying over this canyon, we're looking down, we're looking at the topographic, TOP, topographic landscape. When we're down in it and we're looking at the slices, we're looking at the tomographic, TOM, tomographic slices of the, in this case, of the hillside, but it really reflects what it looks like when we look at retinal tissue as well. So with OCT, we can not only get a two-dimensional slice, what we call a B scan, and those of you that perform ultrasonography in your practice might get a little confused with some of the terminology because we use A scan and B scan in OCT and OCT angiography, as well as ultrasound. So bear with me through this. But basically, we take all of those B scans or those slices that we have of the back of the eye. Those are all comprised of multiple A scans. So in most cases, spectrodomain OCT, that one single line scan that you're looking at is typically comprised of anywhere from 70 to 100,000 A scans across that scan to build this B scan, if you will. Now, if you take multiple B scans, you can then build a volumetric or a three-dimensional view of the retina. And we do this on a lot of different systems. They're either called cube scans or raster scans, or there's several different names for it, but basically it's taking multiple B scans across a section of the retina and then using all that information to build a three-dimensional model in the back of the eye. Now, typically, I don't know about your practice, but most of the practices I'm involved with, they don't really use the three-dimensional function much. It's kind of a neat tool to look at. It's kind of impressive sometimes, but for your sort of quick and dirty diagnostic values, typically the OCT B scan or that line scan is what is used for the most part. So you get a lot of information by just doing OCT. You also get a lot of different views that we really haven't used much in the past that we're actually going to jump into a little bit, especially talking about OCT angiography, because it is OCT technology, but we're looking at it a little bit differently. So remember that topographic view I talked about? That's kind of what we're going to be using when we look at OCT angiography. However, what we're actually using is something called en-face imaging or on-the-face imaging. So it's a different way of looking at things. We're so used to looking at fluorescein angiography, ICG angiography, and OCT, and our minds are kind of wrapped around that concept. Now we're going to combine the two of them. So it gets a little confusing. And initially, if you're just starting to use OCT angiography in your practice, it can be a little confusing looking at just images and trying to figure out, is that an angiogram, a fluorescein angiogram, or is that an OCT angiogram? But looking en face, as I said, basically means looking on the face of something. So when you look at this image, this is an OCT-A image or module that was used to capture this. We're not looking at the OCT-A image. What we're looking at on the left is the en face infrared image. So we're looking on the face of this particular slice or slab of the OCT. On the right is your OCT-B scan that we've seen in the past, we're used to looking at. However, you'll notice there's this pink line that sort of runs through it, this segmentation line that kind of comes right through this pathology here, right through the retinal anatomy. That indicates that that is where this particular picture on the left is taken. So we're not looking at the surface of the retina. We're looking way down here in the choriocapillaris. And if you look down here on the bottom, there's actually a tool to kind of guide you through. You can look at the just the OCT fundus, basically just an IR picture of the top of the retina. You can look at the vitreoretinal interface next to it, or the mid-retina, and where we are here, the inner segment, outer segment, or elliptical zone, which is actually just above the choriocapillaris. I misspoke there. And it's above the RPE. Now, if further down, we're looking into the choroid, so we're actually looking under the RPE if we were to scroll that down through there. So the idea is that these OCT cube scans that we're building, we're able to do B scans of a retina, but we're actually able to look at it from the top of the retina all the way down to the bottom. So we can actually take multiple slabs or cuts, if you will, all the way down through, much like a CAT scan or an MRI does. When you're looking at those images, you're sort of looking at it as it goes from whatever top of the top of the anatomy you're looking at all the way down through. So if we're following this through like this is what a typical CAT scan or MRI might look like, going down through the brain. So we started sort of at the front of the face, or the top of the head rather, and we're coming all the way down through, down to the brain stem down here. So pretty soon we're going to get through the brain and down to our eyeballs, and it'll look a little more familiar when we get there. So you can sort of see it forming here. So here are our eyes as we sort of go through there. So we're kind of scanning all the way down through. So we're past that point now. So think about that in OCT angiography. We can actually look at a slice or a slab at the very top of the retina. So we can actually look above the retina. And then we can look at the very top of the retina where the internal limiting membrane starts up there, down to sort of the middle of the neurosensory retina. So we can look at superficial vasculature and that sort of thing when we're scrolling through. And we can look at just like the choriocapillaris, or just look at the area above the RPE, which is termed the avascular zone, because there are no blood vessels normally in that area. Here's some examples of en face. If you look at different pathologies looking en face with the infrared, things really jump out at you because these gray tones really provide a great contrast. On the top left, we have the vitreoretinal interface, which means that's right at the top of the retina. And you can see there's some neovascularization growing off of there. And next to cystoid macular edema, you can see these sort of flowered pockets of fluid around the fovea. And then an epiretinal membrane really shows up very well on the superficial or very top part of the retina. Here's an example of Best's disease when we're down in the ellipsoid or ISOS junction, and then drusen, and then polypoidal choroidopathy, which we'll discuss a little bit later on. So if you think about OCT in this way, standard OCT that we're looking at on the left-hand side is like looking at ultrasound of a fetus. So we can see a side view of it, but we can't see the complete 3 dimensions of it. When we get into 3-dimensional OCT, when we can build these models, it's sort of like the 3D ultrasound. Well, now we have 4D ultrasound, where we can actually see movement within there. And that's where we're keying in with OCT angiography. So think about OCT when it sends that infrared wavelength of light through the back of the eye, and it looks at the tissue structures as it comes back through. Now imagine several of those scans right after another, in sequential scans, immediately one right after another. And then the system will actually look at all of these scans and figure out what changed between these scans. And the only thing that changes that fast in the back of the eye is blood flow. So all the other structures of the eye do not change that rapidly, or they don't even change at all, or they don't move at all. But blood flow is moving in the back of the eye. So what we're actually doing with OCT angiography is we're recording blood flow in the back of the eye. We're not measuring the flow. We're actually just recording what's moving in the back of the eye. It's kind of it's a strange concept to kind of wrap your head around. But if you think back to high school physics, the Brownian motion effect, basically we can see movement by particles that are suspended in solution bouncing off of other particles. So that's how we sort of see that sort of that motion effect is we know it's moving because things are bouncing off one another in there. So because all of these blood components are made up of mass, when that light passes through that and hits it, it actually records, okay, this is mass. Then the second scan that goes through, or sequential scans that go through, they don't see that mass because it's moved out of the way. So it knows that that's actually moving, so it records it as such. So using that idea of Brownian motion effect and the light reflectivity from OCT technology, we're able to actually see what's moving or flowing in the back of the eye. So we're going to get more into the sort of diagnostic tools or interpretation tools. But on the left-hand side is a color depth retina map. And on the right, you'll see this is a slab, if you will. I'm not sure if you can make out the pink segmentations or purple segmentation lines down here, but it's at the very top part of the retina. Then under that is what we call deep retinal plexus. And then down above the RPE is the avascular retina. And you'll notice there's blood vessels in superficial retina and deep retina. And this is really, really key. This is one of the major advantages of OCT angiography is that we can now see the deep retinal plexus blood flow. We can't see it on fluorescein angiography. And if you look at the superficial retina next to it, this is what we see in fluorescein angiography. We see the superficial vasculature of the retina. That fluorescence from that superficial vasculature masks any fluorescence underneath there in the deep retinal plexus. And remember, we're looking en face, essentially, with fluorescein angiography. So we're really only looking at the top surface of the eye. We can't see down underneath that because we can't penetrate with white light through those structures. But with OCT angiography, because we can actually take out segmentations, we can actually look at segmentations of the retinal structure by itself. We can see the deep retinal plexus all by itself. And that, I'm going to show you how that comes into play later on when we're looking at different diagnosis, retinal diagnoses. On the left-hand side, the color depth retina map is a little confusing because there's color to it. And it's obviously false color. But the idea behind this is if you take all of those slabs and put them together, now you have and you present it as a two-dimensional picture. How do you know what blood vessels are superficial retina, what blood vessels are deep retina, what blood vessels are abnormal, like a choroidal neovascular membrane? Well, you assign color to them, depending on what depth they are in the retina. So in this particular image, these orange blood vessels represent the superficial vasculature, and the green blood vessels represent the deep retinal plexus, which is underneath that. These two complexes are actually connected through vertical connections through here, but some disease pathologies actually affect the deep retinal plexus much more than they do superficial retinal plexus, which might explain a lot about patients' symptoms and how they present to you. So again, we take all of these repeated B scans. Remember, a B scan is a single scan that's made up of 70 to 100,000 A scans. So we take multiple B scans and we create three-dimensional renderings of those B scans and we get our OCT angiogram from that. Simple as that, right? So we can do, and this is not 3x3, obviously, this is about 3x6, but we can do 3x3 millimeter structures or scans of the retina. And typically, this is a very useful scan to use because we get a lot of data through here. We're taking all of these data points, and in this particular case, 240,000 total A scans. We're basically looking at all of those data points in a very small area. As we move out, and software is rapidly changing, and this will change in a lot of the different systems you'll see coming down the pike here with upgrades and that sort of thing. But as we go from 3 millimeter to say 6 millimeter, we have those same amount of data points, but now they're sort of stretched out a little bit. So those of you that remember using time domain OCT back in the Stratus days, those OCTs, if you look at them now compared to the spectral domain, look grainy. And that's because they only use 400 A scans across that scan instead of 70,000 or 100,000 A scans. So because of that, you're going to have this more grainy look to it because you don't have as much data coming out. Well, think about it this way. If you take these 3x3 scans and you move them out to 6x6, 8x8, 12x12, the farther out you go, the more space you'll have between your actual data points. So you're not going to get as much information coming out. And again, this all changes as upgrades and software upgrades and new technology comes out. So this is probably the most important way to think about OCT versus OCT angiography. OCT will give you anatomical structure. You can see the anatomy. You can see every layer of the retina. OCT angiography will show you vascular structure. So when I look at vascular structure, I don't know what layer I'm in typically. I can't see the outer plexiform layer. I can't see the internuclear layer like I can on OCT. But what I'm looking at is all it's showing me is whatever is moving. Anything that is not moving is going to be black in this image. Anything that's moving is going to be white. It's simple as that. It's just like fluorescein angiography in that respect. That's about the only way you can really compare it to fluorescein angiography. The other difference is in fluorescein angiography, unless I've got a patient who's 8 years old and very cooperative, I'm typically not going to be able to see every single capillary around the fovea like I do on OCT-A. But I'm able to capture this because it's showing whatever's moving in the back of the eye. So here's an example of, and again, this is post-production. Photoshop, this is not, your software doesn't do this, but on the left-hand side is a fluorescein angiogram, very early phase of the angiogram. You can see that the veins are still black and the arteries are white. Immediately we see hyperfluorescence right in the fovea. So we know there's in this case, it's a CNV, it's a choroidal neovascular membrane. So we know that's leaking. But immediately at 14 seconds, it starts to leak, and it only gets brighter and bigger as time goes on. On the right-hand side, you'll see this is the OCT-A of that same patient. You can see that same neovascular complex like we can see on the left, but because we're not looking at leakage, there's no dye involved, we're not looking at staining, leakage, pooling, any of those type of functions you see on fluorescein angiography, this is not going to change. So we can take this image on the right at 8 o'clock in the morning and then take it again at 10 o'clock in the morning and it'll look exactly the same. Whereas a fluorescein is more dynamic. You can actually see that dye leaking over time. But what we see on the right-hand side is you can see every single capillary that makes up this neovascular complex. So you're not going to get any obscuring of that neovascular complex from hyperfluorescence. So this is where it really is essential. You can actually see the lesion size without worrying about, Jesus, is bigger than it really, or bigger than it is, or is it just hyperfluorescence that's making it appear that large? We can also see through hemorrhage in a lot of cases too. So in fluorescein, because of we're using this blue wavelength of light, we can't see through hemorrhages. So we can see some leaking on fluorescein in this patient with a choroidal neovascular membrane, but we don't know how big that really is. It could be as large as this hemorrhage. We don't know. But on OCT angiography, again, we can see every single capillary involved in that. Now, bear in mind, these two images are different magnifications, so the lesion looks huge on the right. It's actually just really magnified. But again, you can't see that hemorrhage here because that hemorrhage is a clot, basically. It's not moving. So it eliminates any of that. But you can see this green, which shows up as the neovascular complex because everything's moving within that complex. The other thing I want to keep in mind too is that we do get two-dimensional tomographic B scans from these OCT angiograms because we are using OCT technology. In most systems, they do provide these B scans with what's called a B scan flow pattern, if you will. So if you look at the flow in here, you can see in this particular image, what it's showing is that anything that's red is moving, anything that's green is moving. And because we're looking at linear scans, this is where it gets a little tricky. Anything red is represented in red here indicates retinal vasculature. Anything green represents choroidal vasculature. But if you look at this RPE detachment, you'll see there's red underneath that. That doesn't mean there's a retinal or a retinal vascular vessel underneath the RPE. It's just if you follow this pattern here, you can see that this actually should be green because it's under the RPE. It's clearly a neovascular complex. So it's actually mislabeling that a little bit. So just be careful about what you're actually identifying these vessels by their color. In the practice I work with, I try to avoid using these two colors. I just use one color so I know where flow is. I can see active flow. So all of these green and red basically indicate that there's flow or movement in here. And I'll show you where that becomes really key later on. But here with this RPE detachment, if it was all black in here, that would mean that there's no flow in there. So that means there's fluid there, but there's nothing actively moving in there. So it could just be chronic fluid that just isn't going away. In this particular case, because there's a lot of green in here, that means there's movement in here. So that's either means that there's turbulent flow of fluid or there's a neovascular membrane in there that's flowing, blood is flowing through those vessels. So when OCT-A first came out, it was very novel. Nobody knew really what it was all about, what we were going to use it for. So it's not a push button technology. So it's not a point and shoot device by any means. There's a lot you really need to understand about it. And because there's all of these hundreds of OCT scans that go from the top of the retina all the way down through, essentially down through choroid, the doctors really don't want to spend time scrolling through every single one of those looking for the pathology in there. And at first we really had no idea what we were looking at. So we had to kind of start from the beginning of this, and we had to figure out what was normal before we can figure out what was abnormal, because that's the only way that's going to work. So we had to scan hundreds of patients. And the reason I'm bringing this up, so a couple of years ago, I co-authored a textbook on OCT angiography with Amir Kashani, who's out in LA, and probably one of the smartest people I've ever met. And we wanted to produce this textbook, but there was no literature out on OCT angiography at that point. So what we did is we scanned literally hundreds of normal eyes to be able to establish a normal database. So we knew what normal looked like in our minds. Okay, now we know what normal looks like. Now we can look at these other scans and define what is not normal, what's abnormal, what's different about it. So we had to start from the beginning and kind of work our way up from there. So here's some examples of 3x3, 6x6, 8x8, 12x12, and a 12x12 montage on the bottom right here. So you'll notice in the 3x3, this is the same patient on these scans, not the 12x12 montage, but the others are all the same patient. You'll notice that on the 3x3, I can see these sort of aneurysmal changes, and I can still see them on the 6x6, but they kind of go away here on the 8x8, and they're really gone here on the 12x12. I can also see these gray patches in here. Now remember, anything that's white is moving, anything black is not moving. Well, you can assume that these areas down below the fovea where there's black, that there's no perfusion there. And you can see these gray areas here. That means that something is moving in here. Now, one of the things we have to be very careful about it, we cannot definitively say that this black area below the fovea is non-perfusion, because this is not a dynamic test. We're not looking at fluorescein or dye going through the vessels. We're looking at a snapshot in a moment in time of the blood flow in the back of this patient's eye. If I took a picture, say, 2 seconds later, and that there was actually blood vessels that were perfusing through this area, then that would mean that that is not non-perfusion, it's impaired perfusion. So we can't really call it non-perfusion with one image like this. We really want to refer to it as impaired perfusion. So the crazy thing is what are all these gray clouds that we see up here that we don't see? They kind of go away in the 6x6, and they're definitely gone as you get wider out into the field here. We're going to get to that in just a second. But one of the most important keys, or one of the most valuable assets that OCT angiography can give you, is the ability to track patients' change in their pathology from visit to visit to visit. Now, so this is an example. This patient came in January 2016. This was a few months after we first started using the device. We started using it in December of 2015. But you'll see they've got this very large choroidal neovascular membrane, and it looks like a footprint up here. All this blue is abnormal blood vessels. You can see the OCT-B scan on the bottom. There's definitely elevation. There's activity going on where it shouldn't be. So we started treating the patient with intravitreal injections, and 3 months later, this is what their neovascular complex looked like. And then 3 months after that, it looked like this, and then 2 months after that, it looked like this. So you can see it sort of breaking down as time went on. The OCT-B scans really didn't change a whole heck of a lot. They look a lot better here, but there's not as dramatic a change as you see on OCT angiography. So realistically, I can't do a fluorescein angiogram every time this patient comes in. But I can do an OCT angiogram every time they come in, because depending on my system, and this particular system is the Angioplex from Zeiss, it takes about 6 seconds to get this image. So I can do this undilated, preferably undilated, because I want a clear media, and I don't want them to have fluorescence in their eye. I don't want them to have applanation being done or anything to disrupt the tear film. I really want a really good clear media to be able to shoot through. But I can follow this as time goes on, every time they come in, every visit, so you can see the changes going on here. So one of the things we learned early on is we thought, okay, if I go back to this patient, all of these blood vessels are going away. We're shrinking these blood vessels, and they're actually gone. They're not there anymore. And what we found out quickly was they don't really go away. They just stop flowing blood. So they're still there. Those neovascular complexes are there. So if you see a patient with a choroidal neovascular membrane and you look at the choriocapillaris, or where this neovascular complex sort of started from, when you treat the patient and they're no longer leaking or fluorescein, you don't see a neovascular membrane on OCT-A. What you will notice is a dark area in the choriocapillaris typically. And that dark area means that there's no blood flow going on in that area. So what is in that area? And that is that choroidal neovascular membrane that's no longer flowing. It has mass, but it's not moving. So it's actually, the mass is actually pushing all the normal blood vessels out of the way, and it's just sitting there not perfusing. So they're empty blood vessels just sitting there. And the reason you figure that out pretty quick is when you stop treating these patients and they have a recurrence, it's always in that same area, and you can trace that vessel pattern. Sometimes they grow off of the the older existing neovascular complex, but typically those blood vessels that are sitting there start perfusing again, and they start growing off of there. So I always sort of relate it to weeds. So you spray Roundup on a weed and it dies. When it grows back, it kind of grows back in the same spot. So kind of the same idea with that. Here's another example. So there's a patient who had this patient actually had a very large RAP lesion, and we'll talk about that in a little while. But this is the blood vessel I'm looking at right here, this very large blood vessel coming down. These are normal superficial vasculature up here, but this is an abnormal blood vessel coming down. And you'll see, if you follow their OCT down on the bottom, you'll see they had the subretinal fluid and a sub-RPE fluid here. That the fluid kind of goes away as time goes on, but there's still mass there. And you can see, if you look at the 330/16, there's a very large vessel coming down. 2 months later, they come back and it's gone. There's no blood vessel there. But look at their OCT. It really didn't change a whole lot from visit to visit. And you'll see there's this larger area sitting down here. Now, when we stop treating the patient, they come back 3 months later, and now all that subretinal fluid seems to be gone, sub-RPE fluid seems to be gone, but now they have intraretinal fluid and sub-RPE fluid. And sure enough, there's that vessel starting to come back again. And here's another new blood vessel that's kind of growing off of it here. So this is a good way to sort of track this. If we track them just using OCT, we probably would have prevented this because we would have kept treating them because they have fluid. So we keep treating them. And we still do for the most part. This was sort of experimental in this case to say, what happens if we stop? And this is what happens when we stop. And here's another example. So this is post-production Photoshop, but this is an overlay of this neovascular complex on top of the angiogram. And this is their initial visit on the left. And then after one treatment, this is a month later, this is what it looked like. So you can see it kind of broken down here. These blood vessels stop perfusing in here, but there's still a dark area around here. So there's still an area where there was a neovascular complex, and the mass is still sitting there, but it's just not flowing. Here's another example. So this is a patient, same sort of thing with this patient. When we first saw them, this large green area is obviously the neovascular complex. Looks like it doesn't belong there. 1 month later, after one treatment, they look like this. So, that's a really kind of a home run if you left it at that. But we had to, of course, keep following the patient. And by visit 5, you can see that this neovascular complex is reperfusing in the same area that you see over here. So you can track it with the vessels and patterns and notice that it's the same outline, same area that this neovascular complex is in through here. So the point is that you have to keep following these patients, not only with OCT-A, but with OCT too. And the interesting thing about this particular patient, just as an aside, they showed up, they were 2,200. At that visit 5, they had dropped to 2070 because that neovascular complex had come back. But if you look at their foveal thickness, it actually dropped down at that visit. So it was the lowest it had ever been. It was about 375 here. So it's important to take everything into account when you do this. You don't just look at one image and say, okay, your vision should be great because your OCT looks nice and flat, or your foveal thickness has decreased. Not the case. Another example, the same sort of thing, neovascular complex, and then after treatment it went away, and when it started coming back, it kind of started filling in that same lacy pattern outline that you see on the left-hand side here. And one of the other important things you want to remember too, when I talked about these slabs or these slices, these hundreds of slices or slabs that go from top of retina all the way down, initially I said when we first started doing this, the doctors didn't want to look at hundreds of slides or slabs, if you will, and they still don't, obviously. So it's important as an imager that when you're getting these images that you actually find the slab that tells the entire story. That's one way of helping the physician out. Instead of giving them the entire scan and having them scroll through to find the pathology, you can find that pathology for them and say, here it is. Here's the neovascular complex or whatever else. But be careful of what slab you actually pick. And much like when we take fundus photography, when I train people in fundus photography, I say, get the sharpest image you can and then push it further and see if it sharpens even more. Because you may think it's the best one, but if you go a little further, you'll notice that, oh, I guess it does look better if I push it a little bit. So in this particular case, on the left-hand side, we can see the neovascular complex here. But if we go down a little bit lower, we can actually see the feeder vessel that feeds into that neovascular complex. Of course, in retrospect now, we can see it over here, but you'll notice it's the same brightness as the surrounding normal blood vessels. So it kind of got lost in the forest here. But when we go down and isolate it, you can really see that very well defined here. And those little gray clouds we saw earlier, remember I said that if it's not moving, it's black. If it's moving, it's white. There is a little bit of an inner, sort of a happy medium there. And this is that gray clouds that we see here. And what this is cystic fluid that's actually turbulent. So there's actually movement within there. If you look at the fluorescein on the bottom left here, you'll see there's the microaneurysms and sort of cloudiness of the leaking microaneurysms. On OCT, you can see there's these pockets of fluid here and maybe a little lipid over here on the left. On the top right is our B scan from the OCT angiogram, and you'll see those pockets of fluid have red in them. Now remember I said red indicates movement, so these red little dots you see here are blood vessels, but the red inside here actually means that cystic fluid is actually turbulent in there. And Dr. Kashani, that I alluded to earlier, actually came up with this term of SPIM, which is suspended scattering particles in motion. So you can see that on the left-hand side, the gray scale, the gray black and white image of the OCT angiogram shows these gray clouds, and they correlate to these red clouds on OCT B scan, flow scan. And the same thing goes in the colorized depth image on the right-hand side. You can see they correlate very nicely with these pockets of cystic fluid. Some of these pockets you'll notice are black. They're not actually, so there's no movement within these pockets of fluid here, but the ones that are red have flow within that pocket of fluid. And one thing that I found out too was, and those of you that do OCT have run into this once in a while, I'm sure, you do an OCT B scan on a normal eye and you can't find the foveal depression. They don't have an epiretinal membrane. They don't have any fluid that's pushing that fovea up. You just cannot seem to find the foveal avascular zone. There's no depression to kind of guide you. So when I started seeing this, I said, I'm going to do an OCT-A on this, see what's going on. So there are people out there that actually have a fovea avascular zone that's actually vascularized. So this patient, I could not find their foveal depression, and I did an OCT-A, and sure enough, they don't have an avascular zone in here. Their vision's perfectly fine. It's well documented now. People have seen this in several different places, but you'll notice is this top scan is the actual line scan going down through the retina, and down on the bottom is corresponding. So the fovea should be right about there, and you'll see there's no depression as we go through. So I could not find a foveal depression anywhere in this normal eye. That's just an interesting thing. And this is the type of thing that when you're doing OCT angiography, or you have that capability, you start thinking outside the box and saying, what would this look like on OCT-A? Why don't I just do a quick scan and see if that even shows anything? So what we've learned so far is that OCT-A is really our go-to to identify macular telangiectasia, for one. We have a lot more MAC-TEL than we ever thought we did before. We didn't really know that until we started using OCT-A. RAP lesions, which are retinal angiomatous proliferation, are really easy to identify, and we'll get into that momentarily. And there is a non-exudative choroidal neovascularization. There are neovascular complexes that are under the retina that just aren't leaking. They're flowing blood through these neovascular complexes, but they don't leak. We may be able to see early changes in diabetic using OCT angiography, which I'll show you. There may be applications in glaucoma when we look at actual blood flow in the back of the eye, and we're looking at the deep retinal plexus and what could affect that and not the superficial. Maybe that has something to do with feeding the nerve fiber layer. And it's an ongoing learning process, obviously. So one of the key things in any type of imaging is not only do you have to understand the technology, but you also have to be able to identify pathology, anatomy, and artifacts as well. So here's a really good case of this. So on the top image here, you'll see is an OCT angiogram that looks like there's a neovascular membrane right here in the center. But if you look at the B scan, which this is why it's important to look at these things, you'll follow the segmentation lines. They don't follow the retinal pigment epithelium. They actually drop down here under the fluid, and they course along here, and then they come back up again. So the reason it jumped out at me is all of this red is supposed to be above the RPE, not below the RPE. And I noticed the segmentation line had dropped down. And what I'm looking at here is normal choriocapillaris vessels mixed in with a choroidal neovascular membrane. So the membrane's really not that big. It's actually picking up choriocapillaris under there as well. So it's important that you look at the segmentation lines and make sure that it's actually giving you the image that you really want, that is not giving you some sort of false information. So when I took that out and I actually did a scan right there, below the RPE at the choriocapillaris, before I started picking up all these, you can see these are choriocapillaris vessels in here. Here's the actual neovascular complex. It's a very new, early neovascular complex growing out here. So it's really not as big as it looks on the left-hand side. So this is another reason to look at this OCT flow pattern, B-scan flow patterns. So I mentioned MACTEL. So we get a lot of patients that are referred to us. Most of our referrals in the practice I work with are from optometrists. And sometimes we'll get a patient that they'll say the patient has macular edema in one eye. And the patient's never had surgery. So, it's not the typical CME you see after surgery. They're not diabetic. So you wonder, why would they have macular edema? And on fluorescein angiography, they present like this. There's microaneurysms around the fovea, and they continue to leak in the late stage of the angiogram. And then on OCT, this is what you see. And because a lot of optometry practices use solely OCT and they're not doing fluorescein angiography, this is correctly identified as macular edema. But why is that leaking? What's going on? Why is there a large system? Why is there these little pockets of edema throughout here? Now, fluorescein angiography kind of gives us our answer. These microaneurysmal changes are very common in macular telangiectasia, and they continue to leak and cause the macular edema, obviously. But if you had OCT-A, you can do the same sort of similar scans and see these microaneurysmal changes. You can see some impaired perfusion around here, and you can see this little cloud here that indicates there's edema. And of course, that corresponds to this little red cloud down here on the OCT-B scan. Now, remember when I said that the superficial retinal vasculature is separate from the deep retinal plexus? If you look at the deep retinal plexus, that layer of vascularity under the superficial on the right-hand side, you can really see there's evidence of these microaneurysmal changes, and there's a much larger area of impaired perfusion than there is on the superficial vasculature here too. So it's another reason to really look at that deep retinal plexus. Sometimes it can actually be a lot more affected than the superficial vasculature. Here's another quick case. So on OCT, a lot of intraretinal fluid, large pockets kind of coming down pretty far here. On fluorescein angiography, a lot of leaking, a lot of microaneurysms going on. So obviously, MACTEL patient, when we do their OCT-A, you can see it actually doesn't look too terrible. There's a lot of strange vessels that are twisting and turning, and there's microaneurysms, and there's impaired perfusion. But look at the deep retinal plexus. It's a very large area is affected here, and you can see these microaneurysmal changes around the periphery of that. So why are we really paying attention to MACTEL? There's not much we can really treat. We can treat the edema associated with MACTEL, but it's probably going to come back again. But what we want to be careful of is to watch these patients that are at high risk for developing a RAP lesion. Now, I mentioned that earlier. RAP is retinal angiomatous proliferation. It means that there is a neovascular complex under the retina, but instead of coming from the choroid, a new blood vessel breaking through Bruch's membrane and feeding into it, it actually is a new blood vessel that's branching off an existing normal retinal blood vessel. And the retinal blood vessel, new blood vessel, will dive down through the intraretinal tissue down to the subretinal space and feed into a neovascular complex. So it's a little bit of a different animal. And it's very easy to identify in OCT-A. This top left image is an OCT angiogram, and you can see this very odd looking vessel kind of pattern here, but follow the vessel along towards the fovea and you'll see it makes a quick turn and dives down. Vessels don't do that normally. And if you look at the OCT B-scan flow pattern, you'll see there's the fluid here that's represented in black. That's not really turbulent. But look at this bright red spot here. That is actually that RAP lesion, that blood vessel that's starting to dive down in here. And it hasn't quite gotten down in here yet. This is very early start of a RAP lesion. And here's their OCT down on the bottom here. You can see that large pocket of fluid. And the intraretinal fluid you see here is that neovascular complex sort of diving down. When the new blood vessel starts diving down through intraretinal tissue, it's a new blood vessel. So it leaks fluid, it leaks serous fluid, plasma, just like any other neovascular membrane does. So if you do an OCT on a patient and you see subretinal fluid and they say, oh, the patient has a neovascular complex, but you see along with it, you see intraretinal fluid, the first thing you should think of, this may be a RAP lesion. That has to do with OCT, not OCT-A, but just as an aside. So here's another patient that came in that was sent over for macular edema. So when I do a scan, OCT scan, I can see this triangular sort of pattern always sort of tips me off that maybe there's more to this. Maybe it's a macular hole. So I'm going to scan really well and try to find that macular hole. I didn't find one, so we did a fluorescein angiogram. And early fluorescein, you can see these microaneurysms going on here, and they continue to leak, and sure enough, it is macular edema going on here. And then here's the OCT-A. This is more of a type 2 type of macular telangiectasia where we don't have the aneurysmal changes as much obvious on here, some small ones, but you can see how large the foveal avascular zone is here, and there's that cloud of fluid in here, and then the deep retinal plexus shows a very large area here. One of the other reasons I put this image in here is to show you one of the other artifacts that we can see are motion artifacts. And because we're doing this scan, it requires this patient not to move during the scan, not to blink, not to move around. But if they have microsaccades, even in that 5 or 6 seconds it takes to get this particular image, if they move, then you're going to notice these motion artifacts. You'll see the sort of gray line, linear line, horizontal line. But look at the blood vessels, they don't line up. So the blood vessels are like they've been shifted. Like I took this entire middle portion and shifted it over about, a couple millimeters. So it throws all the blood vessel connections off. Some patients, you can't get them not to move because they don't realize they're doing it. It's microsaccade. You have to just basically accept what you can and go with the image that you can get with that difficulty. So let's talk a little bit about RAP lesions. So again, retinal angiomatous proliferation. This patient showed up. When I see this OCT, I see, all right, they've got an RPE detachment. There's their Brooks membrane down there, and it's fairly intact, kind of hard to see because we have shadow defects or artifacts here. But what really tips me off is this intraretinal fluid and this little area right in here. So this is the new blood vessel that's growing through the retina. It's leaking all the way down, and this is where it breaks through, right in that yellow circle on the bottom. On fluorescein angiography, it looks pretty normal in the beginning, and then it leaks in the end. You can see the cystic fluid of the intraretinal fluid leakage going on here. But now that we know that it's a RAP lesion, you can look back at this top left image and see these blood vessels going right down towards the fovea and sort of connecting. And that's where that neovascular complex is, where that RAP lesion sort of comes down through there. When we look out on an OCT-A, if we look down the chordae capillaris, there's that connection I was talking about there that's starting that new blood vessel. But if we start looking at these slabs, so what I do is I go right down to the problem. Here's this neovascular complex on the top right. That's where it's starting to grow from. Now I'm going to back up a little bit. And as I back up and go up to the deep retinal plexus, I can now see where it connects up here. So a neovascular complex coming from the choroid, you wouldn't see that in the deep retinal plexus. It would be down below that. So this tells me it's coming from above. Plus the B-scan on the bottom is really actually a brilliant example of a RAP lesion. You can see that the Brooks membrane on the bottom is fairly intact. There's RPE fluid underneath there like we saw. And this bright red you see in the middle here is that RAP lesion that's coming down. And you can see all this red here. This is where it breaks through and it's actually leaking into this area down here. So it's like we caught a moment in time as it's moving through there. Here's another example of a RAP lesion. I'm not going to, I have hundreds of these. And again, it's very easy to identify an OCT-A. Of course, ICG is a really great tool for RAP because part of the problem with fluorescein angiography identifying RAP lesions is they leak right off the bat. So you really can't see where it connects or where that comes down to or where that lesion is being fed. On ICG, though, because it doesn't leak out of neovascular vessels, the ICG dye doesn't, you can actually see it very well. You can see the neovascular complex, and you can actually see the retinal blood vessel that flows back from it here, and even a connection up above it here, and maybe even a third connection over here as well. So ICG is really great for that. But if you don't do ICG, or you can't do a fluorescein angiogram, or you really don't want to do one or need to do one, you can always do an OCT angiogram. Here's all of this volcanic activity under the retina on the B-scan on the top and all the intraretinal fluid. And if you look at OCT angiography, there's a lot of intraretinal fluid, but that bright green you see there, that's that neovascular complex. It jumps right out at you. So, what I just said was if you don't have ICG or you don't want to do a fluorescein, well, now you don't need to do a fluorescein for this particular case. And this is one of the key elements of OCT angiography and integrating it into your practice is you're quickly going to find that once you wrap your mind around OCT-A and you understand what you're looking at, you're not going to do as many dye angiograms as you typically would, because you can see this much better than you can on fluorescein angiography. Maybe not ICG, but if you don't do ICG or have it available and all you have is fluorescein, this actually gives you more information than fluorescein angiography does in a lot of these type of cases. So here's looking at that neovascular complex in the deep retinal plexus. You can see it's starting to form here. And now one of the other artifacts I want to talk about, and the reason I didn't lump artifacts into one section here is because I wanted to show them as we see them in the clinic. If I look at the choriocapillaris on the right here, I can see that neovascular complex. And there's an artifact called projection artifact, which it will actually take it will project the superficial vasculature onto the avascular area. So you'll see the pattern of superficial retinal blood vessels in the avascular zone where there shouldn't be any blood vessels. Now, in the beginning, it was kind of annoying, and most systems allow you to eliminate projection artifacts, but I actually leave them in because A, I've learned to ignore them, and B, they're very helpful in RAP lesions because this is way down in the choriocapillaris. I can see this neovascular complex here, and because of the projection artifacts, I can see the retinal blood vessels that actually feed into this neovascular complex. So this image alone gives me all the information I need, because I know I'm in the choriocapillaris, there's a neovascular complex that shouldn't be there, and it's fed by retinal blood vessels. And one image that tells me everything I need to know there. Here's another quick case too. Fluorescein angiography, again, leaks like crazy. The optic nerve's over here, so it's sort of a parapapillary neovascular complex. On OCT, you can see there's some loss of retinal pigment epithelium, so that foundation's gone and all the upper neurosensory retina's kind of caved in. And you can see there's mass going on here, and there's intraretinal fluid. So late fluorescein angiography, you can see that there's leakage early on. Now that we know we're talking about RAP lesion, kind of gives it away that this vessel right here looks a little suspicious going through there. On OCT-A, here it is in the choriocapillaris. There's that neovascular complex. When I took the projection artifacts out, when I put them back in, now I can see that retinal blood vessel that feeds right into it right there because of the projection artifact. And if I look at the depth encoded, it's clearly obvious that this neovascular complex is fed by this retinal blood vessel that kind of comes off from the left here. So choose your modality, choose what works best for you. But this color image alone it tells you everything you need to know. This is another example of a patient that came in that had central serous retinopathy. You can see that pocket of fluid. You can see they have the subretinal fluid. They've got a little blip in their RPE, which is why we started thinking, maybe this is a choroidal neovascular membrane and not a typical CSR. But if you look at the fluorescein angiogram, early in the angiogram, we start to see this little hyperfluorescent area that doesn't really change. You can argue it gets a little brighter here, but this is about 8 minutes into the angiogram, and at 5 minutes it looked exactly the same. So nothing's really leaking there. So we can't really identify a choroidal neovascular membrane. But if we do OCT-A, we can identify a choroidal neovascular membrane. This is it right here. You can see that clearly in the left, and on the right, the depth encoded, it really kind of jumps out at you as well. And then if we look at that little blip that I was talking about, you can see there's a lot of movement activity within there. So that is that choroidal neovascular membrane. So this gave us a lot more information than the fluorescein did. So earlier I had talked about the fact that when perfusion stops in these choroidal neovascular membranes, you're left with sort of this dark area in the choroid. Well, let's sort of look at it from the opposite point. So if you do a scan on a patient, an OCT angiogram, and their choriocapillaris has a dark area in it, that should jump out at you and make you wonder why there's no choriocapillaris vessels flowing in that area. So here's an example. This patient came in and they were being followed for wet AMD in one eye, and this is their other eye, dry AMD. So looking at their angiogram, early, late fluorescein, nothing much going on, just sort of some staining. ICG, nothing really happening here as well. When we follow them on OCT-A though, here's their flow OCT V-scan on the right-hand side. So this is March of 2016, you can see there's a dark area in the choriocapillaris that was kind of off to the side and didn't really, this is a retrospective study, so I wasn't really paying attention to it. But in the middle of it, there's a sort of blood vessel that kind of darts across here. But on OCT V-scan, it looks completely normal. 2 months later, you can see this area here looks pretty much the same. Nothing's changed, but look how big this darkened area is now, number one. Number two, look at that blood vessel I was talking about. It looks a little bit bigger as it's kind of going through here. And this area that got kind of bigger out here has some other new blood vessels or small blood vessels that are perfusing through it that look a little odd. Then a couple months later, we see the patient, and if you study the OCT V-scan on the right, you'll see it really hasn't changed a whole lot. I've circled this area because that's the area of activity, but you don't see a lot happening here. But look how large this dark area has gotten now, and these sort of little blood vessels that are starting to sort of grow into that area, if you will. They're sort of crawling across there, look a little suspicious. So the point of this so far is that if you followed OCT V-scans, nothing's changed. So there's nothing going on in this patient. But watching the OCT-A, there's definitely something happening down there. Now, when we see this patient a couple months later, now we've gone from, we first saw this patient, it was in March, and now that we go all the way to November, the OCT pattern looks the same, the B scan, there's nothing really happening here, but look at the OCT-A on the left. Now it's a very large dark area, and there's a very odd looking blood vessel that's kind of coursing through here, and some other blood vessels that are still kind of crawling across here. Finally, in December of that year, we started seeing a little bit of fluid going on down here, possibly. If you don't look close, you probably might have missed it. Look at the OCT-A. Now this is a very large feeder vessel that's fed into this neovascular complex, and all of this up and around here is all starting to form together. And then finally in February, so almost a year later, we start seeing little pockets of fluid very clearly here. And on the left-hand side of the OCT-A, you can see that's a large neovascular membrane, and there's the feeder vessel that fed into it there. So this may become a more prognostic tool than we ever could have thought it could be, because we can start seeing these happening and following these patients much more closely, really doing a lot of dense scanning in that area, really following that area and making sure we see if there's any changes early on, rather than having the patient present with fluid and then loss of vision and then difficulty recovering that vision. So having said that, talking about prognostic value of OCT angiography, so there is a particular animal out there called non-exudative choroidal neovascular membranes. We've never been able to see them before because they don't leak. So here's a patient that comes in with dry AMD. They have that typical drusen look to their OCT. We did a fluorescein. They've got some early leakage, looks like, but it doesn't really change over time. It might get a little bit bigger there, but really it doesn't look a whole lot different between 3 minutes and 6 minutes on the right-hand side there. So it looks more like staining. But this is what's living in their choriocapillaris level. It's a mass, this is a 3x3, and I didn't actually capture the entire lesion because it was bigger than my 3x3 scan. But this is a very large neovascular complex that's just it not leaking. So one of the thoughts is, I published a paper in the Journal of Ophthalmic Photographers Society on this particular entity, and Phil Rosenfeld did a very big study on this. And one of the thoughts is that these vascular cellular junctions in the vascular walls are more tightly compacted than in typical neovascular complexes. So they're not leaking out any of that fluid, or if they are, it's leaking very slowly, and you're not able to really to appreciate that neovascular complex on anything but OCT angiography. Here's another case. If you look at the OCT on the bottom, even the flow pattern in here, the flow pattern actually shows that there's a little bit of elevation and there's some activity underneath that, which is this little small bean going on here. This is in February. And then a year later, almost a year later, they come back and it's much larger. But if you look at their OCT, it looks like almost like maybe something's going above the RPE, but it's dense, so it's not fluid. It's not leakage going on. And even up here, it looks a lot bigger in the OCT angiogram flow V scan. Then on the right, if you when we follow up on this patient, it's gotten much larger. Now it's a neovascular complex. Now it's an issue going on. So again, the prognostic value, what if you could rewind the clock and go back here to their first visit and say, all right, this is a new blood vessel going on here, and treat it in whatever way it can be treated. I'm not a physician, so I'm not going to get into that. But if you could treat that before the patient's vision is affected, then they don't lose vision, because once they present with 20/60 vision, it's hard to get them back to 20/20 with a neovascular complex like this. So, so there may be some value in that, certainly. Here's another quick case. This patient came in, they had typical drusen-looking RPE elevations here. Their fundus photo looked pretty normal, but this is living under here. So this is following this patient for quite a while. It's about a year or so. You can see in the beginning in the top left, there's the very early starts of a neovascular complex. You can see the outline of it. And then a couple months later, you can see it's very large here. And it just continues to grow and to form into a well-formed neovascular complex that never, ever leaked. So we decided, all right, we're going to follow, if we follow all the OCTs, if you look at the very beginning here in August 2016, all the way down here to over a year later, it pretty much looks the same. It really hasn't changed a whole heck of a lot, especially if you follow it all the way through here. We decided we're going to do a fluorescein. So when they were seen in the middle of all this, and so this was August 2016, and then in May 2017, we decided let's do an angiogram. Nothing's really happening. You know, we thought, oh, there's a leakage there, but it really didn't amount to much. This is, 7-8 minutes into it. There's nothing going on there. But there is that neovascular complex sitting under there. So just be aware that even though the patient presents with dry AMD, scan them anyway, because you never know what you're going to find. I talked earlier about the diabetic foveal avascular zone changes. And this is a little bit of a sticky wick, if you will, with a lot of people. But if you look at a patient who has no clinical retinopathy, you can't see any dot blood hemorrhages or anything like that. They're your typical one-year follow-up check on diabetes. They look normal, but you do an OCT-A, and you can see some microaneurysmal changes here. And the question was, this is where it gets a little sticky, is these areas, darkened areas in here, is that non-perfusion? Is that impaired perfusion around the fovea? If you compare it to a non-diabetic. And here's another area over here in the bottom right of that OCT angiogram of the diabetic. Now, the problem is, here's an example I did with a patient. So they look completely normal, not one dot blood hemorrhage, they're diabetic, their OCT looks completely normal. I do an OCT-A and I have to question, are these non-perfusion or impaired perfusion parafoveally? Obviously, there's nothing we're going to be able to do about it, but is that what's going on here? Now, keep in mind, I said earlier, this is an important thing to remember. This is a snapshot in time, is all it is. It's not dynamic. These parafoveal capillaries are incredibly small, which means that there may be smaller capillaries within this quote-unquote impaired perfusion bed that don't perfuse as fast, or they only allow one red blood cell at a time through, that you're not capturing at that moment in time. So if I scan these patients over and over and over a one-day period of time, I might see different flow patterns around the fovea. So just be careful about jumping to conclusions with that. There's a lot of studies going on. There's some papers out about it now. So if you want to research and look into it more, again, it might give us some prognostic value, but we're really not going to do anything for these patients. There's nothing we can treat them with, but may give the physician an indication to follow them more closely instead of an annual exam. And again, those separate entities, that superficial retinal vasculature and the deep retinal vasculature, are separate, although they are connected. And some of the disease processes, like branch retinal vein occlusions, can affect the deep retinal plexus much more so than it can the superficial vasculature in here. So just be aware of that you need to look at both layers. So sometimes it'll look fine and superficial, like this patient with a BRVO doesn't look too terrible. They have some areas of impaired perfusion around, but in the deep retinal plexus, it's very obvious they've got a large area of impaired perfusion in the deep retinal plexus. So we're still learning about that entity and that vascular bed and what it can actually contribute to and what it does. So just to wrap this up, and again, we could have done 2 hours of nothing but case presentations in here. Bear in mind that it has many, many applications, some of which we're still learning about and we're still discovering, which is why I encourage everybody who has OCT angiography to think outside the box, push the limits. We're still sort of pioneers in this. We're still sort of forging our way. Even here we are 4 or 5 years later with OCT angiography, and we're still finding things out that we really didn't know before. And communication is obviously key. Make sure that everybody's on the same page of what you're looking for, what you're looking at, what you're looking to give to the clinician to be able to make a proper diagnosis of that. Scan everybody you possibly can. And of course, there is swept source OCT angiography out there. This talk isn't about that, but that may become more prevalent, maybe more useful than swept source OCT in typical clinical practice versus academia or research. So just kind of keep those things in mind. And again, this is the book that I published with Amir Kashani. It's still available out there. You can find it on BrysonTaylor.com. You can also email me. So my email is Darrin, D-A-R-R-I-N, @BrysonTaylor.com. If you have any questions, anything comes up while you're scanning patients or later on, shoot me an email. I'm more than happy to answer any questions you may have. I want to thank you all for your attention. I appreciate it, and have fun scanning.